We used really small femoral heads. We used a direct lateral approach. We would actually just saw right through the trochanter of the hip, flip it up. We would make a 3-foot incision. You could see everything very nicely. We would cement hips in. We would cement the socket in. We would cement the femoral component in. We'd put it all back together. You'd take the trochanter that you sawed off and you'd put it back down, cable it back into place. And interestingly, this worked wonderfully. We still see these. Every once in a while, one of these will still pop up in your office. So we've done a lot of things to change. We think we always have the best thing since sliced bread. This is what it looked like. You can see here, this is the cabling technique to put the trochanter back down. Your abductor musculature attaches there, and it's really the key workhorse to the hip. So, you know, these folks did have some abductor weakness, but this worked really well. So we have to sort of hold this as, this is where we started. It worked really, really well. So whatever we do better be at least as good as that. It tended to be very durable. At 20 years, 73% of these were still going. So this was a great thing. I think the key here is that this is such a good procedure by any method that it's a little hard to discern differences. You know, I put that picture on there because, you know, trying to be funny a little bit, but this is really, as an orthopedic doc, at least in my line of business, which is generally hip and knee replacement, this is the most fun thing to do because you get a lot of happy people. You guys see them. I mean, whether you're in primary care, orthopedic therapy, whatever you do, I mean, you guys get to see these people. They're generally happy fairly quickly, and that makes you feel good. So this has been very good. It's had 90 to 95% success rates, low complications. You know, with modern implants, we're seeing up to 85 and higher percent survival at 20 years. A lot of this really wasn't due to the technique that we use. It was really due to somebody accidentally sterilized our plastic with irradiation, and they found out that seemed to make things wear much better. They figured out the correct dose of irradiation, and now all of our plastic we use in hips is irradiated, and they last much longer. So I know we have people in the room here that do this all different ways. This is my disclaimer. These all work, and I think everything, like every decision you make in life and in medicine, everything has a trade-off, a complication, a pro and a con. So I thought we would just kind of have fun and go through some of these. Okay, I like to think of the lateral approach as the old standby. I don't know why this guy's picture made me think of that, but or he's a settler. I don't know. We're settling for the old way of doing things. But this is a great way to do it, and I will occasionally use this approach. I don't know, does anybody here, so I know we have a couple direct anterior guys. Yes, direct anterior guys? Yep. Do we have any anterolateral folks, modified Harding, anything like that? Yeah? Yep. And I will say I do a little bit of this. But basically what this is there's a few different versions of this, but this is sort of the tried and true. Most of what hip replacement grew up with was this. And essentially what you're doing is you can position the person either on their back or on their side. You cut down through the skin and the iliotibial band, and then this is the trochanter. So this is the bursal sac would be sitting right there if we were talking sports magic. But we just kind of go right through that. And then this is the abductor musculature. So the key with most of these approaches is how are we handling the abductor musculature? Are we going in through the front of the hip, the back of the hip? And what this does is you remove about a third of the abductors anteriorly, reflect them, and go make a capsulotomy, and you do your total hip. This is how you would position somebody. It's a little bit of work. This picture is representative because it's a little work to position people this way, especially if their body habitus makes it a little challenging. You can do this supine. Most people do this lateral, and that's what the positioning looks like. Some of the good things about this is what most of our 25, 30-year results are from. It's from an approach like this, or the transtrochanteric approach. Has well-documented low complication rates. I think a very key factor here, and I know my anterior guys are pretty good at extending their approaches, but by extensile I mean if you have a difficult operation, if something goes wrong in your operation and you break the femur and you need to be able to see further down the femoral shaft to fix what you just screwed up, You got to be able to make your incisions longer, get to those areas, and deal with the problems you've created. And I think that's an important thing. This approach is very extensile. Because you're going in from the front of the hip, not the back, you don't have as much posterior dislocation, so it's a very low dislocation rate. And you can see things pretty well here. I think the cons here, this is the big knock on this approach, is you get persistent abductor weakness in a relatively high number of people. The statistics are, you can find a study to show what you want, but it appears that about 25% of people have persistent limping because of abductor weakness, and I could have Dr. Westerheide show you that again, what that looks like. So you do disrupt the abductors, which are sort of you really try hard to stay out of those as much as you can in hip replacement surgery. So that's really the main con to that approach. The posterior approach is where the masses probably sit. That's where the crowd is, I think, right now, although this demographic is shifting. At one point, 70% of total hips were done through a posterior approach. I think that number's probably a little different in 2016. So a posterior approach is folks are lying on their side. You're making an incision on the side of their hip, a little more towards their buttock. You're going behind the abductor musculature here. And again, we keep mentioning the abductors. They're sort of the workhorse that we really want to preserve. The one thing that you do resect here that I think is worth noting is in order to get into the back of the hip, the piriformis tendon and the short external rotator muscles, you actually remove them from the back of the femur, and you need to do that in order to get into the hip. So that's sort of what our approach looks like. The main disadvantage of posterior approaches are dislocation. So posterior approach dislocation positions are things like bending over and twisting. And some of this is controlled by how well we do our job with our hip replacement, but some of this is patients have to comply. And there are certain things like pillows we use to try to help them comply, especially in the first few days after surgery when they're not so with it, or maybe somebody doesn't comply with instructions all that well. But there are a few things, usually bending over 90 degrees, crossing your legs, and twisting while you're bending over are the things that we like to keep people from doing if you do a posterior approach. So this is probably, I would say, the most frequently cited disadvantage of the posterior approach. So in the pros, there's large numbers of these. This was done for a long time in a lot of locations. There's a lot of data on it. We pretty much know what it is. It's a safe, low complication way. It's very extensile, has good visualization, but it does have increased rates of dislocation compared to everything else you're going to see here today. The rate of dislocation is a little higher. I think you could also cite disruption of the external rotator muscles as a potential con. I don't see a whole lot of people complaining to me they can't turn their foot out enough, but you attempt to repair these, but they probably don't repair particularly well. So the anterior approach was yesterday's hot item. Probably not so much now because there's a later and greater one out now, but I don't know, I just want to put that picture in there. So the anterior approach is for most people done in the supine position, and essentially what you're doing here is you're going into the hip from the front. So the abductors are going to be lateral here, so instead of going behind the femur and taking down the short external rotators like you would with the posterior approach, you go in from the front. I don't know, Ty, was that your picture there? Yeah, he made that incision a foot longer after he took the picture. And I don't believe those were Ken's pictures from last week. It took him 3 years to get one to look that good. And he made it sound like it was a random one from last week. So in the anterior approach, what you're doing is you're splitting some of the muscles in the front of your hip. And I think this is one of the things, and I'm not a huge proponent of the anterior approach. I do some of this. But I think that the part about this that philosophically is really neat, this is a true internervous plane. You're really going through muscle groups that are supplied by different nerves. You're not splitting any muscle. Yeah, you beat things up a little bit and push them around, but this is a philosophically a good approach. It's done in the supine position. This is not the only way to do it. This is the only way I've ever done it. I'd like to try to do this without a table. I know some of the folks that work out of New Albany here do this tableless, but there are some positions you need to put the patient in during this surgery that are challenging to do without the help of this apparatus. And what this does, this just helps you position the femur so that when you go in from the front, you can apply the femoral component. This is also allows, these are made of radiolucent material, so you can bring in a C-arm and you can actually image this as you're doing it. You can check the position of your components and your leg length. So the pros here, I would say and we have literature on this stuff now. It's relatively new, but we have a low dislocation rate. There's a shorter, this is the most important one I think probably to mention here. So there are some really good studies done in the last couple of years on anterior versus posterior approach. And everybody's thought is that the anterior approach recovers people more quickly. And we're all prisoners of the moment. And I know when I started doing this, I sort of thought, wow, these people are doing unbelievably well. They're recovering more quickly. And in fact, they do. I don't know if it's an incredible amount, but what the study showed was there's a shorter time to ambulation without walking aids. So there was about a 10-day difference in posterior approach versus anterior approach. They would get off their canes, walkers, 10 days quicker. They had a little bit less pain in the early rehabilitation period. And then they sort of started to all merge together as they got out towards 2 months from surgery. You can use image to guide the implant placement. So you can check your cup position and your leg length before you wake the person up. There's minimal dissection, and again, it spares the all-important abductors. I think the cons here are, there generally are a little bit longer surgical times, a little higher blood loss. Most of the studies cite slightly higher rates of wound complications. It's an area I found in my patients that I tend to end up with fluid collections and seromas, and your skin in the front there, as it kind of comes up underneath where your belly maybe hangs over just a little bit, that little crease there doesn't like to heal. There's a little preponderance of wound healing complications. By using a table, and not everybody uses one, I think we add potential complications with, you have to twist these legs really hard to get that hip to come forward, and there are reports of ankle fractures and tibia fractures and things like that. There is a significant learning curve to this, so as you're learning to do this, it's challenging and your complication rate may be a little higher. And then there are some minor nerve complications that are fairly common. Superior approach is the new hot thing. I don't even know if this is hot anymore. It's Facebook, for crying out loud. It's probably Twitter, and then, well, I don't know, what is it now? Snapchat, and then there's 3 other things now. You're up on that stuff.
Yeah, I got it all.
Yeah, he's got it all. He was over here working on his what?
Bitmoji.
Bitmoji. So he's working on a Bitmoji. I'm still talking Facebook. I'm a little behind. So what direct superior is, I just wanted to include this because I think you're going to start hearing about this a little bit. Direct superior is just another way to do a hip arthroplasty. Again, we make big deals out of these being all different. They're all just different ways to skin the cat. But what this is somewhat like a posterior approach. You go behind the femur, but instead of taking down the short external rotators, you make a little capsulotomy, and you do it from the top down. The incision's a little different. This is starting to gain a little bit of popularity. Any of you guys doing this stuff? No? My take on this is a posterior approach that sounds fancy, so that if you don't like doing the anterior approach, you can say you're doing something special to your patients. I think that's what this is. It purports benefits of no hip precautions. It spares the external rotators. All you have to do to extend this into a posterior approach and be able to see whatever you need to see is cut down the external rotators and make your incision a little longer. I think the cons of this from the couple people I know that do this, it makes it difficult to put your acetabular component in right. You can't bring the C-arm in because you're not supine. And we have no data, but we don't worry about that. We don't worry about data. So every approach has its advantages. You can find a study to say, this is why I do this, and you can take it all the way back to trans-trochanteric approach and probably make a pretty darn good argument why to do that. So I think the key with this is, and some of this is patients come in and they want certain things. You tend to direct them to what you think is best anyway, but generally, in your own families or yourselves, if you just go to somebody you trust and say, do what you're good at. but all these ways work very well. And you know, there is a lot of direct consumer marketing we deal with now. You know, so some recent fads in total hip arthroplasty. I hope nobody hears from Alliance. But this was one of my ads I picked out a while ago. I was giving a talk on something, and there was this super new thing. This was called minimally invasive hip surgery, shortcuts. I know, basically, this was a little fad that we went through where instead of making your incision 8 inches long, we made it 7 inches long and said we were doing something special, and we started advertising. And you know, as we were trying to do surgery through smaller and smaller bits, you know, of course, we don't do a better job. Now we're trying to do something through a cut that big. So, you know, that was one of our fads. Another fad was 2 incision total hips. Anybody here ever do one? Yeah. I mean, conceptually, it's kind of cool. You make 2 small incisions. You make an incision in the anterior aspect to get a socket in, which is a great direction to put a socket in. Then you get this little cut in the back where you can get access. It's almost a superior approach, right? This is the superior approach in a mini form. And so you make these 2 little things. You do it all under fluoro. So instead of making this big, nasty, mean whack, you know, you do these 2 little incisions, and you do it all with fluoro, and it works. You know, people had success with this. Other than a few people who did lots of it, it was kind of a disaster, and there were all kinds of femur fractures and heterotopic ossification because the bone fragments were all over. It just didn't really pan out that well. But that was one of our fads. You know, complications with these kind of things. You know, femurs would get broken here, so instead of having that little mini incision, now we have to open them up and do all this kind of crazy stuff to them. So I guess you know, this is hip resurfacing. Anybody ever, you know, that was. It's still going on. I think there are some people who do this well, and this is still a viable option. It's kind of a total hip with higher rates of complication to me. So I personally wouldn't do this, but I know some people who do it well and have pretty good results. But hip resurfacing was a hip replacement with just this little ball on the end instead of the femoral component. So you know, these were some of the fads that we've been through, and some ways trying to make things better. We sort of took a few steps back. But I think all the approaches we talked about there are reasonable things, and so you just do what you do best. So.